Now I call upon our next presenter, Dr. Dhruv Kamra.
Through the few cases that I'm going to show you, I'll try to emphasize the importance of pattern recognition of scleral lesions and how they may help us in differentiating the two conditions and managing infectious scleritis better. So the first case is a 61-year-old female. She presented to us with chief complaints of pain, redness, and watering in the left eye for the past 3 months following injury with a wooden stick. She gave no similar episodes of redness in the past and no ocular surgery history. She had no systemic illnesses and was not on any long-term medications. On ocular examination, the left eye conjunctiva was congested, and due to a grade 4 nuclear cataract, the BCVA was 20/60 in the left eye and 20/50 in the right eye. The rest of the findings were normal. On diffuse slit lamp examination, we noted a scleral nodule inferiorly, yellowish scleral nodule inferiorly with temporal thinning and uveal show, along with dilated episcleral vessels. We did a UBM through this nodule, and we noticed elevated area of hyperreflectivity within the scleral stroma with overlying thin sclera. The B scan showed acoustically clear vitreous cavity and no signs of posterior scleritis. At this point, we asked the patient to get a complete systemic immune workup done, and she returned back to us a week later with the following reports. The ESR and CRP was elevated. RA factor, ANA profile, C ANCA, P ANCA were all negative. The Montauk test was negative, but she was newly diagnosed to have type 2 diabetes and was started on medications. At this visit, when she came to us a week later, we also saw a new lesion developing in the superotemporal region. It was a boggy yellowish nodular swelling. And due to the negative autoimmune profile and positive history of injury with vegetative material, as well as these lesions which appeared at discontinuously almost 4 mm behind the limbus, we thought of it to be an infectious scleritis, and we took the patient for scleral deroofing and biopsy. The pus was allowed to drain out, and the infective tissue was scraped and sent for microbiology and histopath. 10% KOH mount showed septate hyaline fungal filaments, and histopath confirmed the presence of fungi through gomoromethamine stain. We started the patient on antifungals, topical and oral as well. The scleral biopsy culture grew unidentified demataceous fungi 3 weeks after incubation. By this time, the patient was doing well. The inferior nodule had resolved, and the superotemporal abscess had also healed with thinning and uveal show. 6 weeks after this deroofing, a new supranasal ulceration had developed. We deroofed this as well, and we added topical voriconazole due to the demataceous fungi. 10 weeks from presentation, all the lesions had healed with thinning and uveal show. After this, the patient was lost to follow-up. Coming to the second case, this was a 44-year-old female who presented with pain, redness, watering, and diminution of vision in the right eye for the past 2 months. She also gave a history of wooden stick injury to the right eye 4 months ago. Also, there was history of pterygium surgery in the right eye 3 years ago. And there were no similar episodes of redness in the past, no systemic illness, and she was not on any medications. I'll jump directly to the clinical findings. So the diffuse slit lamp examination of the right eye mainly showed 2 scleral nodules inferiorly with pus pointing, and superior-nasally resolved looking discharging sinus was also noted. We did a UBM and found there were 2 elevated areas with thin sclera and decreased reflectivity within the scleral stroma. There was no evidence of posterior scleritis. Due to the pus pointing and discharging sinuses, a provisional diagnosis of infective scleritis was made, and on deroofing these nodules and sending them for micro and histopath, no organisms were noted. But because the lesions were so similar to the case that we had seen before, and they were appearing in a discontiguous manner 4 mm posterior to the limbus, we decided to start this patient on empirical antifungals. The patient was lost to follow-up, but continued to use the medications, and a month later, the nodules inferiorly had healed with thinning, but new scleral abscesses had formed nasally. On deroofing them and sending them for micro and histo, again, no organisms were seen. However, again, a month later, those also healed, but a new lesion developed superior nasally, which was again deroofed. But again, there was no confirmation of any organisms in micro or histopath. However, we continued antifungals due to the positive response, and 3 months later, all the lesions had resolved with thinning. So to discuss the important learning points, firstly, it's very important to differentiate immune-mediated from infective scleritis before starting any immunosuppressants in haste, because we need to rule out any underlying systemic disorders before we start any immunosuppressants. Also, it's very difficult to manage scleritis with medications alone because of the dense collagen fibers and structure, as well as avascularity. Fungal scleritis is even more challenging because most of the drugs are fungistatic rather than fungicidal. Another thing we noted is that the lesions which appeared on clinical examination intraoperatively much larger, because these fungi and organisms are more invasive and may remain in the deeper stroma, so you might get negative scrapings, but that does not mean that you should rule out any infectious etiology. It's also important to note the difference between fungal and bacterial scleritis, because fungal scleritis is more indolent, takes a very long time. Like in our case, the injury happened 2 months prior, whereas bacterial scleritis is acute and usually presents as a localized abscess in one area, whereas fungal scleritis presents as multiple nodules 4 mm posterior to the limbus. This typical pattern of fungal scleritis can be explained because of the arterial network and watershed zones in the eye. So if we look at the episcleral blood supply, the anterior ciliary arteries and long posterior ciliary arteries are the main blood supply of the episclera. The anterior ciliary artery branches anastomose to form the episcleral arterial circle, which is 4 millimeters posterior to the limbus. And within this circle, the blood flow is...
Dr. Dhruv, you have lost 5 minutes more.
5 minutes. Okay.
I'll just finish it off quickly.
Yeah.
So the main point is that the arterial blood flow in these areas oscillates, and so it stagnates, and the fungi get a chance to harbor their infection over here and grow in these areas. So to conclude, basically, discontinuous scleral lesions due to intrascleral spread of infection 4 mm posterior to the limbus is most likely suggestive of a fungal etiology, and even if you don't get a histopath or microbiological evidence, you may start antifungals for a better prognosis. Thank you.